So we're down to one of the things that blood can do for us when blood vessels are broken or cut or torn. So there's a built-in mechanism in our bloodstream that's set up to stop the bleeding and repair the damage. So when we talk about blood clotting, we talk about hemostasis. Heme for blood, stasis means to stop. So we're talking about blood coagulation. All right. Now, it's sort of a complex thing. It's localized. It happens very fast, and there are several things, actually more than several, going on at the same time that we'll be trying to talk about. And remember that platelets, we said, were essential for normal blood clotting. If you've got a low platelet count, you could very well have some trouble with clotting of blood. Now, so platelets are important for clotting of blood, and a number of proteins that are dissolved in plasma are important in the clotting of blood. There are certain essential proteins that are called clotting factors dissolved in plasma that are important in the clotting of blood. Plus this inorganic substance right here, calcium. Calcium. As a matter of fact, if you've ever gone to the lab to have your blood drawn, they drew the blood, and they put it in some different kinds of tubes, don't they? The stoppers are different colors, aren't they? So you've got maybe a lavender stopper tube that they put some blood in. It's usually a smaller one. And they've got one or more red stopper tubes that they put some blood in. All right, there's a reason for that. Because they want some of the blood not to clot, and they're going to let some of it clot. So they're going to run some tests on the serum, but they're going to take this non-clotted blood, and that's what they're going to do your complete blood count with. All right, if it's clotted, they can't do a complete blood count. All right, now, how come the blood that they put in the lavender stopper tube doesn't clot?
An anti-clotting.
There must be something in there that keeps the blood from clotting. Okay, a common substance in those little tubes. It can be a liquid or a powder, but if you look close, sometimes you'll see a little white powder in the bottom of those lavender stopper tubes. That's a chelating agent that takes calcium out of solution. Something that chelates has kind of a claw-like action that latches on the stuff and brings it out of solution. So that powder is called EDTA, ethylene diamine tetracetic acid. You don't have to remember that. But anyway, what I'm saying is, if you take calcium out of solution in blood, it won't clot. It will not clot. Now notice that even though we have many factors that are involved in clotting, you only have to be deficient in one to cause the blood not to clot normally. Just one. And that's an example I just gave you with calcium. You take calcium out, blood won't clot. Now, there are several phases of the formation of a clot. There's a vascular phase. It has to do with something that happens in the blood vessel. There's the initiation of the action of the platelets. And then there's the initiation of the action of these other protein clotting factors. Now this is just a broad overview. Now when we say that there are phases here, it's not like we do phase 1, and when phase 1 is complete, we start phase 2. These things are happening simultaneously, as we shall see. So it's a very rapid thing, and we've got several things going on all at once. We've got the blood vessel going into spasm, we've got the platelets adhering to the broken edges of the vessel, and we've got these clotting factors whose action is initiated by all of that. So we'll look more at that in just a moment. These words right here, platelet adhesion and aggregation. Adhesion means sticking to something. So when you have an injury in a blood vessel, platelets love to stick to things that are irregular. As long as the lining of the blood vessel is smooth, as it's supposed to be normally, nice and slick, those platelets just stream right along. But if it's broken, those endothelial cells in the lining of the vessel, they will turn inward, and now you've got irregular surfaces that those platelets can stick to. Some of the collagen fibers in the wall of the vessel will then maybe stick into the lumen of the vessel, and these platelets love to stick onto things that are irregular. They will adhere to them. That's the beginning of what is known as a platelet plug. Then once we have a few platelets adhering, more and more of the platelets pile on, and that's called aggregation. They're piling on, and that's what stems the flow of blood initially. That's not the clot, but that's the beginning of a clot right there. The same thing happens in blood vessels that are damaged by atherosclerosis, arterial plaque, atherosclerotic plaques. These plaques first are embedded in the wall, and then as they grow, they begin to encroach on the lumen, and they will stick out into the lumen. And sometimes their surfaces are irregular. They're not smooth, completely smooth, they're irregular. And sometimes platelets will just begin to stick on those. And the first thing you know, we initiate a clot at an atherosclerotic plaque, and if it's in the heart, we've got a heart attack. In the brain, we might have a stroke. So, anyway, that's what's happening with platelets. Now, you notice when you looked on the slides of blood, peripheral blood smears, those platelets were teeny tiny, weren't they? But they are powerful because they are packed with other substances that facilitate and potentiate the clotting of blood. We'll look at those in a moment. When we get down to talking about this phase, we're going to see that there are several pathways. We'll talk about those in a moment. Well, let's talk about them now, just briefly. Here's vascular spasm. Whenever a vessel is cut or ripped or torn, the smooth muscle fibers in it send the vessel into spasm. And when you spasm a vessel down, you tend to slow the flow of blood through it, don't you? Now, will that stop the bleeding? No. Now, in smaller vessels, this is more effective. But if you've got a cut in a really big artery, like say the femoral artery, you cut the femoral artery, and blood is going to spew out of there under pressure. Now, you can stop that by putting pressure on it and help the clot to form, but if you've got a really big vessel like that, you're going to have to surgically repair that. It's not going to clot off by itself. It might clot off by itself, and then the first thing you know, it blows the clot off. So, vessel spasm first, and immediately following, as soon as there's an irregularity in that vessel, these platelets will aggregate, they will adhere and aggregate, pile on, and then we get this other phase, the coagulation phase down here, with these various plasma proteins coming into play, and I'll show you how that works. Now, this is probably not the scheme in its absolute entirety. There are probably some other factors that are not shown on here, but this is generally how it works. Now, this is not something you need to memorize. All right? I mean, you need to understand this, and I'll show you the part I want you to know for sure. But what this is showing you here are the pathways to the clot, which is going to be down here. Now, these Roman numerals that you see here, those represent plasma proteins. Okay, so they're called factors. So factor 12 and factor 11, factor 9, and so forth. Now, this is also showing you the extrinsic pathway here and the intrinsic pathway here. They both lead to the same end result, this common pathway. But let's just say you have damage to a vessel. You have a cut or a tear in a vessel. There's something called tissue factor there that initiates this extrinsic pathway and leads down here eventually, when it combines with activated factor 7, it leads to factor 10. All right, simultaneously, inside the vessel, we've got these various plasma proteins beginning to initiate the clotting process too. So that torn vessel is going to, and the platelet action is going to initiate a series of events. You can think of blood clotting as a rapid cascade of events. A lot of things happening in rapid succession. So what you're seeing here is factor 12 being activated. See, factor 12 is circulating in plasma. It's in your plasma right now. Factor 12, assuming you're normal clotting. All right. When factor 12 is activated because of this going on up here, that activated factor 12 activates factor 11, which becomes activated. The little subscript A means activated. Activated factor 11 acts on factor 9 to activate it. Now we have some of those compounds released by platelets playing in here. Notice that calcium is also playing in here. Here's factor 8, and eventually we get to factor 10. Extrinsic pathway, intrinsic pathway, common pathway. Common pathway starts with factor 10 and ends up with a clot down here. Now, so factor 10 is activated, and calcium and platelet factor 3 and factor 5 then act on this prothrombin activator, also known as prothrombinase. Prothrombinase is the catalyst, if you will, that converts prothrombin to thrombin. When thrombin is activated, it causes fibrinogen, one of the proteins dissolved in your blood, to become an insoluble protein, fibrin. This is the mesh that forms the meshwork against which the blood cells are caught and create that dam effect of that gelatinous mass that is the clot. Okay, so that's how it works. Now, let's go back over the phases. Remember now, this is all happening in rapid succession. So you have a tear or a cut in a blood vessel. You have spasm that occurs immediately. As we said, this is most effective in the smaller blood vessels, as you can imagine, because decreasing the diameter of a blood vessel reduces the flow. That facilitates clotting. The endothelial cells participate because they are torn and they sort of reach across the lumen to help platelets stick to them. This begins with injury and lasts about 30 minutes. Then those platelets come into play. Platelets initiate clotting. So we have platelet adhesion and aggregation that we talked about. Now, here's a list of the substances contained in platelets that stimulate clotting. Those tiny little fragments, cytoplasmic fragments that you observe on the slides, they contain a number of chemical compounds. And these all stimulate or facilitate or potentiate clotting. Adenosine diphosphate causes platelet adhesion and aggregation. Thromboxane A2 causes vascular spasm, platelet aggregation. Serotonin, vascular spasm. These platelets also contain some of the protein clotting factors. some of those Roman numeral factors that we showed you? I think there's something in your notes, isn't there a table in your notes that shows you,
Page 12.
on page 12, isn't there a table that shows you the factors that are contained in platelets? Yeah. All right. You can look at that at your leisure. Now, platelets also contain something that's going to stimulate repair of the break in the blood vessel. This is called PDGF, platelet-derived growth factor. We're not through yet. Those platelets also contain calcium ions. Of course, you have calcium ions circulating in your plasma, but they also contain calcium ions. And they also contain these contractile proteins. Remember actin and myosin in muscle contraction? This causes clot shrinkage and reduction in the size of the vessel break, which is good. Now, this platelet plug that's forming, we don't need it except where the vessel is broken, right? We don't want it propagating all down the vessel. So there's something circulating in plasma called prostacyclin, which is a platelet inhibitor. It inhibits platelets. It also produces vasodilation. So it's helping us to confine the action of the platelets to the site where the injury is. Then we have this coagulation phase. It's started by the platelets. It requires clotting factors. All those clotting factors that you saw that have the Roman numerals on them, those represent various plasma proteins that are involved with clotting. Now, all of these clotting factors are proteins except for one. The one that's not is calcium. It's an inorganic substance, isn't it? All right, so also, all but two of these clotting factors are manufactured in what organ? The liver. I think that table I just referred to showed you that too, doesn't it?
Yes.
Yeah, which ones are manufactured in the liver. So the end result is the clot. Fibrinogen, which is a soluble protein circulating in our bloodstream now, the end result is, in that common pathway, thrombin is going to cause the conversion of fibrinogen to fibrin, an insoluble mesh. And that's going to help form the clot. All right, so again, the three pathways we have are the extrinsic pathway that I showed you, the intrinsic pathway, and the common pathway. This is the one I want you to remember for sure, right down here. The common pathway. Right here. Now, here's an electron photomicrograph of a clot, a piece of a clot. You see this fibrous network in here? That's fibrin. It came from fibrinogen. Okay, the conversion of fibrinogen to fibrin produces this. And you see it's catching these blood cells in its mesh here. This is a highly magnified view of a part of a clot. Now, how many factors do we have to be deficient in for blood not to clot? One. All right. So I gave you an example of calcium, didn't I? All right. Now, I'm sure you've heard of hemophilia. That's a serious bleeding disorder, isn't it? You see this factor right here? Factor 8. Most cases of hemophilia are deficiency of that one factor. Just factor 8. And it can cause all manner of trouble. This is why, for example, people who have a bleeding crisis who are hemophiliacs, sometimes they're transfused with platelets. Right. Why would you transfuse them with platelets?
Because it has the factors in it.
Because the platelets contain factor
Yeah,
VIII.
yeah.
Yeah. You've heard of heparin? Heparin inhibits the intrinsic pathway. You've heard of Coumadin? Coumadin inhibits the conversion of this to this. You who work in hospitals or clinics, you'll know that people who are on Coumadin have to go in periodically to have their prothrombin time checked. And that's because Coumadin, warfarin is a generic name, it's a rat poison, inhibits this right here. What about aspirin? Does aspirin inhibit the clotting of blood?
Mm-hmm.
How? What is its action? It inhibits platelets. So aspirin inhibits platelet action. All right, and now, once the clot is formed and the vessel is in repair or is repaired, do we need the clot any longer? We want to get rid of it and open up that vessel completely now. So that process is called fibrinolysis. Remember I told you anytime you see lysis on the end of a word, it means dismantling or breaking apart. So that's, that's the noun. The verb is lyse. When you lyse something, you dismantle it or destroy it or break it apart. So we have a gradual dissolution of the clot as the vessel is repaired. Now, what substance does that? What substance breaks down the clot and eliminates it? Plasma. This protein, plasma, right here. Now, in order for us to get the action of plasmin, we have to have this right up here. Tissue plasminogen activator, often abbreviated TPA. Oh, I want to cancel. I said no. Thank you. All right, so tissue plasminogen activator. This is actually contained in the clot. And so its action is also aided by thrombin and factor 12. But tissue plasminogen activator activates plasmin right here. Plasmin slowly dissolves the clot. Now, if any of you work in emergency rooms or have an assistant down there, you may have heard them talking about tissue plasminogen activator, TPA. Because nowadays, sometimes this is used clinically in people who come in the emergency room with, say, heart attacks or an early stroke type picture. If the indications are correct, the emergency room physician may administer TPA. And that's going to initiate the action of plasmin. So if there's a clot occluding or partially occluding a coronary vessel or a cerebral vessel, it may be possible to dismantle the clot before it fully develops, and you can restore, hopefully, some flow of blood through that damaged blood vessel. So there's an arterial plaque there or something that a clot had formed on. But you have to be careful. You can't just use this across the board. So, for example, if a patient comes in who had a surgical operation, a major surgical operation a week ago, and he may have a heart attack now, you're going to have to think awful long and hard about whether you're going to give TPA, because what could happen. You can cause bleeding at the surgical site, right? So you have to be careful about that. So there are absolute and relative contraindications. Now, we said that clot is a localized thing, isn't it? We want it to be localized. We don't want it filling up the whole vessel. So why is it that a clot, once it's formed, doesn't keep expanding? Well, for one thing, those clotting factors are diluted by the blood moving past the injury. In other words, you're using up the clotting factors to form the clot. And then the action of thrombin is restricted because a lot of this thrombin is bound up in the clot, isn't it? We saw that down there. Those clotting factors are going to be bound up in that clot. Also, you have the action of heparin. Remember, heparin is an anticoagulant. And it enhances the activity of this substance right here, antithrombin 2, which by its name, you can tell, inhibits thrombin, doesn't it? Okay. And also prostacyclin helps because of its antiplatelet action. All right, here are some terms you need to know. Thrombus, embolus, and disseminated intravascular coagulation. Thrombus is just another word for clot. And it usually, in the clinical setting, is being used to refer to an intravascular clot. In other words, a clot forming within an intact blood vessel. So somebody who's laid up in traction in a hospital, maybe after an orthopedic surgery, you know, they're tied up in traction, they're not moving much, and they've got pressure, maybe too much on the lower limb, and you slow down the flow of blood appreciably, moving through those veins in the lower limb. The slowing of blood can sometimes lead to an intravascular clot called a thrombus. And when that happens, sometimes those thrombi propagate. In other words, they develop a tail, a clot. And that clot just keeps growing and growing, and you've got a clot flapping in the bloodstream here, and sometimes that clot or a piece of it can break off. And if it breaks off in the lower limb, the blood is flowing back to the heart, isn't it? That clot's going to find its way to the heart. It's going to be pumped out of the heart into the pulmonary blood vessels because it's going back to the right side of the heart. It's going to be pumped, I'm telling you stuff you may not know yet, but it's going to be pumped to the pulmonary blood vessel. Now eventually that clot is going to find its way to a blood vessel that it can't pass through. So it's going to hang up somewhere in the lungs. All right. A clot that breaks off like that is called an embolus. An embolus. Now, it doesn't have to be a blood clot. Sometimes after serious orthopedic injuries, you have serious bone fractures, you can get fat, bone marrow fat into the bloodstream. So you can get fat emboli. It's also possible to have air emboli. Somebody getting an IV and they get air in the tube, you get an air embolus. All right, this thing right here, DIC, or disseminated intravascular coagulation, is a relatively rare condition, but it's involved with blood clotting. Now, usually, for this to happen, something else serious is going wrong with the patient. In other words, the patient is sick with something else, and this usually, when it develops as a complication of that. So, for example, someone who is profoundly ill with, say, a bloodstream infection called septicemia, an overwhelming number of bacteria moving through the blood system. This is a very, very serious condition. Sometimes that will trigger this, and it begins like this. You see, it says disseminated intravascular coagulation. Disseminated means happening in multiple spots. So what happens is you have the formation of blood clots many small blood clots in many tissues and organs of the body. And of course, that impairs blood flow to those organs, doesn't it? It impairs their function. Now, in order to do that, you're using up a lot of fibrinogen. And in the extreme, it's possible to use up virtually all of the available fibrinogen in forming these multiple clots. Then what happens next? When there's no fibrinogen, now they begin to bleed from multiple places because they can't clot blood anymore. So this often has a fatal outcome here. It's a complication of something more serious going on.
Dr. Schickler, on the thrombus, is that what happens? What is it, PAD, when they talk about people with poor circulation in their legs, how it causes clots? Is that basically what that is? Because they have the,
What was the first thing you said?
I think they call it PAD, I don't remember, but it's where people with poor circulation in their legs. What is it? BVD? PVD? Okay, I had two of the letters right. But is that what that is? What happens with the
What does that
thrombus?
stand for?
You say it?
Oh, peripheral vascular disease. Okay. No.
No?
Peripheral vascular disease is arterial.
Okay.
Now, you can get clots in arteries too. I just referred to that a while ago. You know, you have an atherosclerotic plaque in an artery. That irregular surface there invites platelets.
Okay.
Platelets initiate clotting, and you can get a clot forming at a site where you have peripheral vascular disease, which in this country is commonly atherosclerotic disease.
Okay.
Okay, that's different from the example I gave.
Okay.
I was talking about the venous circulation.
Okay.
But you can get thrombus in arteries, certainly.
Okay.
That's what happens in heart attacks.
Okay.
That's what happens in strokes.
Because you have an
You have a blockage.
in the
A
artery.
blockage.
Okay.
Yeah. Now sometimes the atherosclerotic plaque itself can almost obstruct the artery. Advanced ones will take up most of the lumen of an artery.
Okay.
So you have very little blood flow going through anyway.
Okay.
People who have angina pectoris probably have that condition.
Okay.
All right, abnormal bleeding. What are some things that cause abnormal bleeding or inability to clot blood normally? Well, platelet deficiency certainly is one, isn't it? All right, no question about that. What about impaired liver function? Where do we say most of these clotting proteins are formed? In the liver. So somebody who has chronic liver disease, you think they might have trouble clotting blood normally? They certainly do. Hemophilias, we talked about. There are different classes of hemophilia, but the classic type of hemophilia, of which about 75% of cases is the factor VIII deficiency. All right, what if we're giving somebody too much anticoagulant? That'll certainly do it. Yeah. And there are various other causes. Back to our example of somebody with an intravascular venous clot lying up in the hospital bed. You know, when the nurse comes around to make rounds in the morning, the patient says, you know, I got my calf hurting a little bit. And so he or she checks that, feels it, it's a little warm and it's swollen. She measures it, and the other one's normal, this one's bigger. She's thinking, or should be thinking, possible clot. So they send the patient down for an ultrasound, and sure enough, clot in the vein. What are we going to do about that? We're going to give them, you might give them a blood thinner, I'm going to give them an anticoagulant. All right? So what anticoagulant might we use?
Heparin?
Heparin, something we can give IV. It has immediate effect. All right? We put them on a heparin schedule. All right? 2 try to prevent embolism. Okay? And so say they make it over the hump, or even if they have pulmonary embolism, you're still going to treat them with heparin. And so they get over the hump, and you're just going to stop the heparin and that's it? No. You're going to anticoagulate them for 6 or 8 weeks at home on Coumadin, usually, or something similar to Coumadin. All right, well, we mentioned blood thinners over here. Our lady over here wants to treat this patient with blood thinners. And did the rest of you want to treat it with the patient with blood thinners too? That's what's called for, isn't it? I'm being a little, I'm dealing with the semantics here, you know. We refer to heparin and Coumadin and Lovenox and all these other things that inhibit clotting of blood as blood thinners, don't we? Well, I got news for you. They don't thin the blood. You tell me that little Coumadin tablet is going to thin the blood? When I think of thinning something, I think of diluting it. If I really wanted to thin my blood, I'd start an IV and put some IV fluid in. I'd thin my blood, wouldn't I? I would dilute it, wouldn't I? If I'm at home painting, you know, if I got latex paint that's too thick, I add water. If it's oil-based, I add mineral spirits or paint thinner. I'm diluting it. I'm thinning it. Okay. So heparin doesn't thin the blood. Coumadin doesn't thin the blood. Okay. Aspirin doesn't. So the proper term is anticoagulant. Now I know everybody calls them blood thinners. The doctors call them blood thinners. But you know, to be specific about it, you don't really thin the blood. So you anticoagulate the blood by affecting this series of events here. Heparin inhibits the intrinsic pathway. Coumadin blocks this. Aspirin blocks that. Okay, any questions about blood? Seems like we've been on blood forever. Okay. Let's go on to the we're going to talk about the lymphatic system. This, you know, the balance of our period here, and then Wednesday when you come back. But I got some handouts for you.